I think our next speaker is our Chief Instructor, Mallika.
Thank you, Dr. Vishali. So basically I'm trying to show a concept here which I recently I realized is useful. Fibrin glue to close retinal breaks in combined tractional rhegmatogenous retinal detachment secondary to PDR with silicone oil in situ. So this is a, yeah. So fibrin glue has been used for ages in systemic surgery for various indications, and also more recently in retinal surgery, and more lately by Dr. Mudit Tyagi, it has been shown for retinal closing retinal breaks in rhegmatogenous RDs, but those are not with leaving silicone oil in situ, and uh, and also for closing macular holes. So we encountered this patient who had bilateral PDR and combined RDs, very poor vision. So very often what happens is that we lose track of the area which is bleeding and keep working in the other areas. Even did scatter laser for the other areas. And by the time I realized that I had to close the brakes were already obscured by blood and other things. So we did a fluid air exchange and tried to remove the blood, but the view was too poor and laser could not be done through the blood. There are two breaks in that area which need treatment. So after several attempts, I thought that maybe in any case we would lose the eye. So I injected, this is being injected, fibrin glue, and it comes as two different parts. First fibrinogen and then thrombin. So you have to inject it separately over the two breaks. Had to dry the area and then injected silicone oil, 5000 centistokes. And you can see that even at 1 week it was attached, which it generally may not if you leave the brakes open and then you ask the patient to position. It takes time for the SRF to resolve. And we followed this patient up, and you see the glue is resolving very rapidly, and it is no longer seen at 5 weeks at the 2 points. Pressure remained normal, and the oil has not been affected. Vision has improved very rapidly from hand movements to 660 and 36. Then this was another lady who had a surgery for RD, combined RD, but the break didn't close in the first surgery. So again, we were to lose this eye anyway, so thought that I would try this in the resurgery. There was a break superior to the macula. That video is not here. So I had to do more membrane peeling around that break to make sure that it would settle, and then used fibrin glue to close that break. And you can see that at 1 week, the entire retina is settled. You can see what was the picture previously and now, and without requiring any post-op positioning. This was actually done before the case which I showed earlier. So we had used little more glue here, and this is the picture at 3 weeks. But she came back a few days back, which is 8 months post-operative, and the entire glue has gone, retina is attached, vision is good, and there is oil has not been affected. So to conclude, fibrin glue can be an useful adjunct in the management of combined RDs with complex breaks with silicone oil in situ, especially with proliferative diabetic retinopathy, where laser for breaks is not possible due to bleeding or other reasons. But it has to be ensured that membrane peeling is complete, there is no traction on the breaks, and the surface has to be dry, otherwise the fibrin doesn't work. And post-operative positioning is not needed. That is an additional advantage. And the rapid resolution of SRF is also another advantage. And the silicone oil did not emulsify even at 8 months, though we did use higher viscosity oil in these cases. Thank you.
You mean to say you put it on the blood, madam? In case there is a blood over covered with the break.
Yeah, So in one of the break was seen through the blood, but it was not, the laser was not happening. The other break could not even be seen well, but we knew where it was. So after multiple attempts at removing the blood.
What when the blood it gets lysed, or the blood clot, doesn't it get retracted? And because in most of the cases where we have seen, even when you see look at the foreign authors, they say that just leave silicone oil. If you are putting a 5000 centistoke silicone oil, you don't need to laser at all. But somehow I'm
No,
now
that
of a
doesn't work.
different opinion. But in these cases, when you know that you can't do a laser, there is a thick film of blood, and you put a fibrin glue, when that blood starts retracting, will not the edges get lifted, or
No, see, as it is, the blood forms a kind of a tamponade over the break, but that's not lasting. The glue probably just adds to it, and you have a tamponade for the time that you need. You have done laser, but you haven't been able to see the burns. So possibly you have some laser effect which you can supplement post-operatively as the blood resolves. But I didn't have to supplement the laser also in these patients. And then in every case, the view is not the only problem. Like the second case, when I went for a resurgery, it was not the view that was the problem, but it had a failed RD because of that open break. So I just thought that since the laser didn't work the first time, actually going and sealing it, plugging it may work. And so their blood was not an issue, but it still helped to salvage a redetachment or a failed detachment.
in how many cases you have used this
No, only
glue?
two,
Only 2 cases.
because it just started October this year, last year.
Okay. And even I think Dr. Mudit has done a large series
Yeah,
where he
that
has
is
shown-
different. That's what I was
That
showing.
was for the simple reg
That is
RD.
why I
Uses
started,
it
because
for the retinal
that is just a simple detachment
Simple
where
detachments.
there is no oil, and I think he removes the glue also. He just puts it and then removes it. But the concern here is whether you can leave it in situ with oil in the eye for several months. That has not been done, not reported also.
Choice of tamponade in these cases, madam, when you use the fibrin glue.
I mean, in these two cases, it was oil only because the detachments are also very bad.
Can you use gas in these cases and ask them to
I
position?
mean, why not? The choice would not change, I guess.
so there-
Because, in fact, in these, once you have plugged the holes, you don't even need much tamponade, because you see in these patients in the first 1 week there is no fluid and there was no post-op positioning also. So I think tamponade is not even important in these cases.
even the air tamponade might work.
May.
The plug is fibrin glue is temporary, it's not permanent.
Sorry?
Fibrin glue is temporary, it's not permanent.
Yeah, of course it is not permanent, but by that
Because
time we
it
can
will
do.
automatically biodegrade by a period of 15 days. So if the attachment by 15 days is okay, then you don't have to give a tamponade. But if you feel that attachment is not good and you need to give a tamponade, then you will have to fill the
Have
eye.
to.
Because it's a biodegradable.
Yeah, absolutely.
And leaving inside the eye doesn't make a difference.
Doesn't make?
Makes a difference.
Yeah, that's right.
Because it's a biological glue.
That's right. As we saw, in 4 weeks, it is disappearing in both cases.
So thank you, madam. In the interest of the time, I
Thank
think
you.
we could have a little more questions on the fibrin glue, but because of the time, I think we are
I'd like to
exceeded
thank
by
the esteemed panelists and speakers
Thank
and the
you.
audience for their patient listening. Thank you very much.